Right, welcome to this second episode in the lecture series, Chronic Hepatitis B Viral Infection. This is the second following the initial one, which was acute viral hepatitis. We shall be looking at other aspects of chronic viral hepatitis. And without wasting your time, I'll go ahead and start showing you the screen so that we will be up to speed again as we did initially. Perfect. Brilliant. I believe you can see this. If any of you is having problems listening or hearing me, unmute yourself and let me know, and we will be able to support you in whichever way we can. Right, so chronic viral hepatitis is where we will be, and I think it's going to be a bit shorter than the initial meeting. And so here we go. Upon the completion of this course, we will hope that all participants and those who are attending and will look at the materials that will be sent should be able to list all the viruses that are associated with chronic hepatitis, recognize the clinical manifestations of chronic viral hepatitis, identify the laboratory techniques, and possibly interpret them for investigating chronic viral hepatitis, and then discuss the management strategies for chronic hepatitis caused by viruses. Whereas all the hepatitis viruses that are transmitted fecal-orally are acute and do not cause chronic infection, those transmitted via blood and blood products are associated with both acute and chronic infection. Okay? So chronic infection means that the infection persists for more than 6 months. Remember that it is about duration. It has got nothing to do with severity of infection, okay? So there are 3 viruses, 3, okay? Hepatitis B, C, and D. Sorry, you could see B there twice. It's D as well. So B, C, and D. Now, the nomenclature B, C, and D has nothing to do with severity. It's again a name, just like you are named Mary and I am named Nimson. Okay, right. So hepatitis B infection is transmitted via blood and body products, body fluids rather. The infection perseveres beyond 6 months, is more likely to be acquired in early childhood. Many of you who have attended previous lectures from here will bear me witness. I've sent a lot of materials that deal with that situation a lot. So we will actually be concentrating on how to manage this condition here. Transmission risk and persons at risk of infection have been handled in previous lectures, okay? But in a nutshell, the risk of chronic infection, in other words, if somebody had acute hepatitis B, what is the amount, the relative risk that that person will go on to having a chronic infection? One, there's about 90% chance that if a baby had the infection, then they would go on to having chronic infection. 20% of older children will progress, okay? Whereas only 5% of adults, in other words, because your immune system is great, if you had the acute infection, you are more likely than a child to clear the virus from your system. So less with higher numbers of age. Hepatitis C is a virus that can infect the liver. If left untreated, it can sometimes cause serious and potentially life-threatening damage to the liver over many years, okay? But with modern treatments, I have mentioned this before, it is usually possible to cure hepatitis C. It's curable, and most people would have a normal life expectancy. Hepatitis D, on the other hand, is a liver disease in both acute and chronic forms caused by the D virus that requires the B antigen for it to replicate. In other words, in the absence of B, D does not survive. Which is some good news, isn't it? Right, so what are the symptoms? Okay. For many people, they don't even know they've got any infection at all. Many people don't even know it. They will just go for the lab test and they are found to have positive test outcomes, okay? Some people would report X and just some kind of non-specific illness. some depression, some just being unwell, some joint pain, some would lose weight, some would never lose weight, some would even be gaining weight. It has nothing to do with the virus at all. Some will come with abdominal pain and some would come with discomfort. By the time that the overt symptoms are manifesting, like jaundice, weight loss, massive abdominal swelling and pain, the disease has progressed. Okay? So when you examine the person, there's nothing, no sign at all. But by the time it's progressing, there's something called stigmata of chronic liver disease. And those are finger clubbing, redness of palms, spider nevi, increased breast enlargement in males, and liver enlargement initially before it becomes shrunken. Okay. Again, this graphical appearance of what the symptoms may be, like I mentioned earlier, they are never specific. They will not always be present in those who have chronic infection or inflammation of the liver. The dark urine, jaundice, abdominal pain, joint pains, it may just not be there. Okay, so all of those symptoms are applicable to all the viruses B, C, and D. Okay, again, you can see that their symptoms the same, and they are non-restrictive. In other words, it must not always be there, but they could be there. And if they're not there, it doesn't mean you don't have the infection. Right, so what investigations do you carry on? In general, this is the blanket investigations you do. Non-FBC here stands for full blood count. What are you looking for? We are looking for low platelets. Why would platelets be low? Platelets are some giant blood cells that are important in clotting. Because if somebody has got chronic inflammation of the liver, it can progress to cirrhosis, and cirrhosis can cause portal hypertension. And that would mean the spleen would become enlarged. And the platelets, when they get into an enlarged spleen, there is something called hypersplenism. The spleen will take back and sequester, keep within itself and damage platelets. And so it presents with low platelet count. Okay. So that's one reason for low platelet count. Okay. That's one of the things that if you find, then it gives some information that something unusual is happening. Liver function test, you are interested in ALT. I mentioned this alanine aminotransferase or transaminase, which may be elevated or maybe normal. So don't rely on that as much, but it's also important that if it's raised, then it gives you some ideas as to what you should do in terms of treatment. The next thing would be viral load tests. Polymerase chain reactions are specific for each of the viruses. Genotype testing is to find if there's resistance to treatment and to guide appropriate therapies. Imaging, which is doing ultrasound, fibroscan, CT scan, or MRI, are all important because nowadays liver biopsies are not routinely being carried out with high degree of accuracy from this imaging. However, there are occasions when it becomes difficult to understand the kind of damage the liver is undergoing, and in which case you want to characterize response to treatment. And so you can go ahead to do a liver biopsy. Okay. Now let's discuss about the specific diagnosis. And here I'm dealing with hepatitis B, and I would pay attention clearly here because many of you have asked me questions about how do you interpret the serology. Now I would spare you the time to look at these parameters here. These are the antigens and antibodies on top and how you interpret them here. Okay. Now, if you do all of these and the person is negative, it means that they were never exposed to hepatitis B. Okay, hepatitis B surface antigen, anti-core antibody IgM, and anti-HBs. I mentioned this to one of you, the questions that came through, and I was mentioning that was the point. So this means there's no immunity, and also there's no infection. So that means that the person has never been exposed. So this person is susceptible to infection if you are living with somebody who has the infection, which means you should be vaccinated. The second line, the surface antigen is negative, but there is evidence that there was an infection, okay? And this tells us that the person has actually cleared the immunity. So the presence of the core antibody here is like a scar, but there is antibody already. So the immunity has been acquired. These are the ones that do not need vaccination, like I mentioned in the first lecture. The third line, also negative surface antigen, but they have the core antibody, but there's no anti-HPS, which is confusing, very confusing. But this is the explanation. They have had past infection, they have cleared it, but the natural immunity they has went over time. And so sometimes you may need to do HPV DNA to find out or go ahead and give a booster dose. The fourth line is the surface antigen is negative. The antibodies are present. The anti-HBs is positive. So you have had immunity, but this immunity was acquired from vaccination, okay? So this is very important that if this is present, then you recognize and are able to interpret that. The other line here talks about when the surface antigen is negative and the anti-core antibodies, the IgM in particular is present, but the IgG is negative, then you're dealing with a recent infection recovered. For example, when we talked about acute viral hepatitis, by month 6, if you can do that and find that the person has these parameters, then they have just recovered from acute infection. This surface antigen present, and then the IgM is present, okay? That is acute ongoing infection, as an acute infection. But the ones that you're more likely to encounter is the surface antigen positive, and then the IgG for anti-HBC is present. That is chronic ongoing infection. Now, these are the categories that define chronic infection that you are more likely to encounter in your practice, or in your case, if you are the patient. So for the C, how do you make a diagnosis? You assess the liver fibrosis doing AST, ALT, and can calculate the APRI score. Now, this is a score that has been validated to be helpful, particularly where resources are limited. In other words, instead of going for fibroscan or expensive liver biopsy testing, you can do the APRI score, and which can help you define whether or not treatment should be commenced or not. If you have facilities, then go for fibroscan or ultrasound. The HCV RNA is a quantitative test, and if it's present, then it defines chronic infection, okay? HIV and hepatitis B surface antigen is important because if you're treating the patient, you need to know what other viruses that needs to be tackled at the same time. Moreover, some of the treatments require that you handle both infections, okay? Alpha fetoprotein is a protein that is produced to indicate the presence of abnormal tumor cells in terms of liver cancer. And so sometimes you need to know how far the infection has progressed. You then go on to performing endoscopy if you find the platelet count is less than 150. That is the lower limit of platelets, suggesting some hypersplenism, which I mentioned earlier, and that's an important factor. For hepatitis D, the test that will give you definitive information is HDV RNA, but of course, again, the HBV DNA is important because D infection does not occur without a B infection. Right, so what do you aim to achieve when you give treatment to patients with chronic hepatitis? Okay, one, you want to stop the progression of liver damage. Okay, that is one important goal, because when you can stop that, then it means that you would have actually supported the patient to recover. Two, you want to reduce the development of end-stage liver disease and or liver cancer from developing. Number 3, while the intention of treatment of OC is to cure the disease, the hepatitis B and D is to keep the viral load undetectable. The reason is that as at now, the ability to clear the D and B virus from the DNA, B virus particularly, from the DNA is limited. It's a complex mechanism that is yet to be elucidated, although ongoing research is happening. The overall goal is to reduce the mortality, okay, by preventing liver-related deaths associated with the development of liver cancer and decompensated liver cirrhosis. Again, the terminology cirrhosis will be defined later on, and I'm happy to continue this lecture on, but it's just that some people will be joining a bit later. So we will keep to the time. Right, so how do you go about the specific treatments for these patients? Compatibility with infection is defined when you have a quantitative viral load in ideal situation, okay? On the other end, if you don't have the quantitative viral load testing, you are able to find that the patient has cirrhosis by imaging. Imaging means ultrasound, CT scan, or anything, or you calculate the APRI score and it's greater than 2, or the patient is HIV positive, you can initiate treatment. The same with if the HBV DNA is more than 20,000, or there's abnormal ALT, remember the enzyme I mentioned earlier, that those are indications that the patient can be started on treatment. And what treatments do we recommend? For adults, tenofovir is the most robust medication that has the least side effects, and is also convenient because it is taken orally. Entecavir, on the other end, is reserved as a second-line treatment and all for children. Okay, for those who have HIV, hepatitis B co-infection, there is a protocol specific for those, and that you will adhere to. We cannot go through this because it's not the scope of the lecture. If, however, there is no cirrhosis, okay, and then the HBV DNA is less than 20,000, or the ALT is normal, you can defer the treatment and monitor the patients instead. For C, how do you handle them? I know many of you here are not excited about C because it's not a very commonly encountered issue in your practice. However, you are looking at non-cirrhotic and treatment-naive patients. There are specific medications which are available for cure. For those with cirrhotic and treatment experience, then there are these medications as well. These are all oral treatments as against the injectables that were used in the past. These were very expensive medications then. They are still expensive. However, there are agreements with the WHO and some important groups, particularly in Egypt and also in some countries in agreement, that are actually helping to cure and give treatments to eradicate this infection globally. For D, the first choice of treatment is to give them an injectable, very expensive treatment, really, pegylated interferon alpha, and then you can add tenofovir to suppress hepatitis B. First 3 trials, bulevirtide is actually in place, being tried in Europe, and has very significant promise of clearance of the D virus, including B as well. That is still being tried, but for now, those are the treatment recommendations. What are the fear complications of chronic hepatitis? Okay, liver failure. The liver can fail. The liver can become replaced by scar tissue known as cirrhosis. There is liver cancer development, kidney disease, and vasculitis. These are general complications, but for in specific terms, rather, hepatitis B is associated with a specific kidney injury that is known as membranous glomerulonephritis. Now, this is important. I mentioned this because some medical students are present who are quite interested in knowing what type of injury it causes, and it comes out commonly in the examination questions. So the membranous glomerulonephritis is important as an antigen-antibody complex immune-mediated injury in the kidney, the glomeruli. Okay. Hepatitis C will cause specific kidney complication due to essential mixed cryoglobulinemia. This can lead to membranoproliferative glomerulonephritis. Now you can see I'm actually challenging, not able to pronounce this very well, but you can recognize how it's only relevant to those who are in the academics. Okay. For D, people who have chronic hepatitis B and D are more likely to develop liver failure, cirrhosis, and liver cancer than those who have only the single inflammation alone. So the presence of D is an ominous sign that needs to be tackled. In summary, chronic viral hepatitis can be caused by hepatitis B, C, and D. 2, chronic hepatitis D occurs only in a setting of chronic hepatitis B infection. 3, the clinical manifestations of chronic hepatitis range from being asymptomatic to full-blown complications of chronic viral infection. Whilst hepatitis C is curable, chronic hepatitis B infection is treatable and can be prevented by vaccination. That is the B form. Guys, this is the end of chronic viral hepatitis lecture. Like I promised, this is the second part of 3 series. The next part would be management of cirrhosis. You have the schedule in your time, but if you don't, I will explain to you that you're likely going to be getting an update of timing, but it's going to happen just shortly from after this one, probably in about 40 minutes time. I'll stop sharing this screen now. You can unmute yourself or show your screen so that we can see who we're talking with at this point. Perfect. So you can unmute yourselves or show where you are to us, and you might show your video if you want us to see you as well.
Good afternoon, sir.
Great. Thank you. Thank you, Rodger.
I see your great work. I'm enjoying the lessons. So for this, thank God you have lectured me well about this chronic hepatitis. So when I was told that I was having chronic hepatitis, I was, wow, I'm going. But by the grace of God, you have lectured me much about this hepatitis. Because I discovered that I was having hepatitis more than 15 years back. But I didn't start the treatment just last year that I started the treatment. But with what I had today, with what they have been doing in the hospital, I see there's a progress. But I want to ask, what are those things that I should avoid taking, that eating? Actually, you have told me about alcohol. Thank God I'm not taking alcohol. And I don't know what all this red oil, granite oil, red meat, I don't know. Which one will I avoid?
Thank you very much, Rodger, again for interacting with the contents of all that we've been talking.
Yes,
moreover, I've seen some other additional comments from Nanma saying thanks for a great lecture, and Nandom as well saying great work, sir. Thank you very much for your supportive comments so far. Now, in regards to eating and things not to eat, I always am of the opinion that food should be eaten with discretion.
Okay.
For hepatitis B, my comment is because of the limited amount of food available to us, it is non-restrictive. In other words, the list for things you should avoid are the ones you should concentrate on. Okay. In particular, the avoidance of alcohol is very important. Now, if you are a very big person, in other words, at risk of having fatty liver, even if you did not have hepatitis B, I will advise on going on a diet that will help you lose some central weight. That way, you will reduce the load on your liver and ensure that the medications you're currently taking will have effect. So we all know that frying foods is not great. Frying foods is never a great thing at all because it destroys some nutrients in your system, in the system of the food, and also takes away a lot of multivitamins that will be relevant for your feeding. So what you're going to derive from is not great. Moreover, they come with lots of excess cholesterol, which again deposit in your liver. If you have a choice and a chance, then barbecue or doing some kind of roasted food may be a bit better than fried ones, or cooked food rather. Those would be better. Again, a lot of people have avoided protein diets. I will not encourage that. You need to eat protein. If you don't, you're going to be losing your muscle mass. In other words, those proteins that your brain requires will come from the ones that are already in your system. So false teachings have come to many, and they have been avoiding things that should have been of benefits to them. I've got an app that talks about liver nutrition, which you can find in Google Play Store. Liver nutrition, which I would recommend for you to go to. All right. Any next question, please?
Thank you, sir.
Thank you. Someone, Gabriel here said, thank you for impacting this knowledge on us all. Thank you very much, Gabriel, for those comments. Mr. Danjuma, were you going to say something?
Yes.
Go ahead, please.
Okay. I quite appreciate your lecture, and I've really gained a lot from going through those lectures. I joined lately, but I quite appreciate all the efforts trying to enlighten us on hepatitis B. I want to find out, you said when the viral load is over 20,000, then tenofovir will be administered. Then at the point, if you keep taking the tenofovir and then you repeat the DNA test and it's less than 20,000, at what point are you expected to stop taking the tenofovir, or is there any other way one can actually take care of that since the viral load is less than 20,000?
I think you're asking a very intelligent question that is often asked medical students and also postgraduate medical doctors. And so that is, you can be an examiner to them. But I'll tell you, that is not an easy question to answer. However, the practice is that once you have commenced treatment on for hepatitis B, chronic hepatitis B, you should not stop the treatment. This is the reason, because the difficulty is that you're not, even when the viral load is undetectable, it's unclear at which point the virus will start coming out from within the cells of the liver again. There are a few exceptions. In other words, if there are facilities to demonstrate that you have cleared the virus from your system by doing the hepatitis B surface antigen, it has become negative, and or some complex mechanisms. And of course, even if the surface antigen has become negative, you are supposed to be on the tenofovir for 1 year at least before consideration to stop should be made. But then you will be required to monitor for as long as you are alive, so that if there are reactivations, you are then recommenced on the medication. So brilliant question there. But there are exceptions. We can chat about that. I know we're connected on social media in many ways, so we will be able to chat about that part at some point. Thank you very much.
I have another question.
Okay, go on.
Okay. You see, there's always this perception that once you have a liver disease, you are not expected to overwork the liver by taking proteinous food like meat, beans, and other things. The reason is because you said that if you take such kind of meals, they overwork the liver. So in which case, we often advise to avoid taking meat or other proteinous food. But somebody asked a question much earlier, and you said you would rather prefer the person to be taking proteinous food. So I don't know, I'm a bit confused.
Very beautiful rendition there. In the past, when knowledge was poor, that was the thinking. People thought that was the case. But if for those, there are doctors who are here connected as well, but they will bear me witness that there's something known as first pass metabolism. Whatever food that enters our body, apart from some fat which are absorbed through some lacteals, those are different pathway of absorption. Every food that you eat passes to your liver before being taken into the system. In other words, through the portal circulation. Now, that is very important. So everything, whether you've eaten carbohydrates or proteins or fat, whatever, it will still pass through the liver. So there's nothing about overworking the liver. The liver is there to be overworked anyway, to give some things to our system. So whether you eat, you avoid protein, or it will still pass through the same liver. So there's nothing about that. It's all wrong teaching, if ever it was taught to you. So eat your protein, because it's something we know in our systems that is very important. We call the essential amino acids. Those are important for your brain functions and many parts. If you do not eat the protein, then your body will release the protein that you need for your brain functions through another mechanism. That will lead you into a hypercatabolic status. In other words, you will be getting sick and unwell for no known reasons. Thank you very much.
Thank you very much. I appreciate it.
Thank you. Thanks, Benjamin. Any more questions? Well, it does seem like Nandom Beatrice. Okay, so yeah, that's fine. There's no. You were going to ask a question, Nando. Were you going to say something? You said my questions. Maybe I've answered your questions, perhaps.
Good morning, sir.
Very good. Hi, Nando. Go ahead. We've got about 5 minutes.
Okay, I have 2 questions. I was trying to type them actually, but in the chat space. You made it clear that if a patient who has chronic Hep B infection could have or develop portal hypertension, and that one can detect when one check blood platelet levels when it becomes low, below 150.
Yeah.
Yes, I was just wondering, in that setting, why do endoscopy? Why not something a little more less strenuous for the patient? Because endoscopy is really not an easy one. I'm just wondering whether there could also be other means of assessing the portal pressure rather than do endoscopy. That is one. And then you didn't mention hepatitis E antigen as one of the things one should look at when trying to initiate treatment for chronic hepatitis B virus infected patients. I don't know.
Okay, I'll start from the last one. The E antigen aspect is contained in my bigger lecture on chronic hepatitis B that I dealt with in detail. This was an overview, so it did not contain all the details that I would have given to everyone. But that is also an important part. And part of the combo test, I should have actually highlighted that, but it was going to make it a bit bogus, and particularly so because in most African patients, they don't have the E antigen. And so that is going to be a bit confusing. Now, let's go back to the platelet and its role in defining portal hypertension. The platelet is important, yes, but it is not sensitive. In other words, in a particular proportion of patients that may have portal hypertension, they don't have a low platelet. But if it is low, then there's a high chance. In other words, more specific, but less sensitive. Those are the terminologies which me and you will know and understand. And so endoscopy is important. Secondly, endoscopy will be additionally able to provide some treatment, like doing banding of viruses to prevent bleeding. So again, we do know that the resources are not easy to come by, but if one can afford, and that has to be checked, then go ahead and please provide that care for patients. Does that answer your question?
Yes, sir. Thank you very much, sir. I'm grateful.
Thank you very much.
Yes, sir.
I appreciate your joining us. Thank you very much again. I hope there would be time for the cirrhosis part, which will show us some little bit of pictures and introduction into managing the complications of cirrhosis. Okay, right. So without questions, I will exit this now, and we will welcome you again in the next couple of minutes. Have a look at your invitation pack, and you will have, the time we should be starting, but I will update you via messaging when it will start. Bye-bye.